I think it is not full screen yet.
I have made it slideshow mode, sir.
Okay.
We are live, please.
Is it okay now, sir?
All good,
Yes.
doctor. We are live. Dr. Kidev, we are live.
Good evening, everyone. I welcome you all to today's iFocus online session. Today's it is episode number 425. Currently, we are running in the 39th cataract module. So today we have Dr. Neeraj Khunger, sir, senior consultant at Center for Sight, Ajmer, to talk on mix and match of IOLs at various scenarios. We have Dr. Prafulla, sir, to moderate today's class. Sir has finished his MD and senior residency in cornea, cataract, and refractive surgery department at RP Center, AIMS, New Delhi. Sir is currently an additional professor at RP Center, AIMS, and also a secretary at Delhi Ophthalmic Society. He's the chief editor of Ophthalmology Clinics 2, and postgraduate ophthalmology book series. Sir has published 395 Google Scholar articles, 156 of PubMed index papers, 50 chapters in national and international books. Sir has won Best Surgical Technique Awards from RANSCO, Young Achiever Award ISCKRS, Ajit Babu Maji Award, and awards for best papers in various conferences. Sir is a principal investigator in 2 ICMR trial, co-principal investigator in 18 trials, including 2 multicentric international trials. Sir is also a teaching co-in-charge at RP Center since 2016. Welcome, Dr. Prafulla, sir. So we have Dr. Brikaurav Kapoor, sir, as our chairperson. Sir is professor and HOD ophthalmology at AFMC Pune. Sir is a trained refractive surgeon. He has won awards and honors in first in grading exam in 2003. Sir is a chief of Army Staff Commendation in 2014. Sir has won a second in MOSCC 2016. Sir also has 30 international and national publications. Sir is a winner in second best article MJAFI 2014, best AFMRC project 2014, best innovation award in 2019, BPOS in cataract segment in AIOC 2020. Sir has one thing under the apple tree winner in AIOC 2020 again. Sir is also a patent holder for angle chopper and dialer. Sir is an examiner for NBE, GGS IP, MUHS, PGIMS Rohtak. Welcome, Dr. Brikaurav Kapoor, sir.
Thank you.
We have our speaker as Dr. Neeraj Khunger, sir. Sir has finished his MBBS and MD from AIMS, New Delhi. Currently, Sir is working as a senior consultant at Center for Sight Eye Hospital, Ajmer. Sir is a vice president of Rajasthan Ophthalmological Society. Sir has served as chairman, scientific committee of Ajmer Ophthalmological Society and organizing secretary of ROS Conference 2013 at Ajmer. He's one of the pioneers in phacoemulsification surgery in Rajasthan. Sir has participated as faculty in live surgeries in phaco and SICS workshops and has multiple presentations as faculty in various ROS conferences. Sir also has scientific papers, surgical videos, instruction courses in various national and international conferences. Sir has won gold medal for distinguished services in ophthalmology by Governor of Tamil Nadu and IIRSI conference in 2014. Welcome, Dr. Neeraj, sir. I would like to request Dr. Neeraj, sir, to share his screen for the presentation.
Thank you, Dr. Krotka, for such a wonderful introduction. So my topic today is mix and match of IOLs. Okay, so first of all, what is the need of mix and match IOLs? Basically, that we are now gone from cataract surgery. I have seen era of ICC, ECC, then phaco, and then various IOLs. So we have gone from the era of just cataract surgery to IOL surgery, and now it is basically a phaco refractive surgery. Our patient wants very good distance vision, near vision, everything, and he wants spectacle independence. I have no financial interest pertaining to this talk. Now, what is the concept of an ideal intraocular lens? A lens which provides perfect vision and seamless accommodation from distance to near without aberrations, a loss of contrast sensitivity, no dysphotopsias or PCO, or a loss of function with time. And as we all know, there is no such ideal IOL available as of now. Thus is the need for mix and match of IOLs. Because every currently available IOL has its own advantages and disadvantages. Combining different IOLs in a single patient may enhance the outcome by maximizing his or her vision while reducing unwanted side effects. So what are the challenges? The rapidly increasing adoption of LED lighting is creating a new challenge for good vision quality in low light conditions. The rapid shift to digital platforms has created a rapid increase in far through near vision demands. Despite numerous IOLs options today, patients still struggle to find a lens that can perform at their ideal distances and lighting conditions. Advanced refractive procedures have prompted cataract surgery to be a refractive surgery. This gives edge to newcomers over old traditional surgeons. So how can we address this shift in patients' needs? Coming to past and current status, since the advent of multifocal IOLs of silicon era, we had been doing bilateral refractive IOL implantations, mix and match of diffractive and refractive, bilateral diffractive, accommodative IOLs, multifocal in one eye and EDOF in other eye, trifocals, continuous range of vision IOLs, continuous range vision IOLs and EDOF, mixing these. I think I'll not go into the details of diffractive and refractive, but I'll just speak one line here is that in diffractive, it is the wavefront technology that we are using. Thus, the defocus of the point, like we are basically having two focal points. The one that is defocused on the retina has a uniform spread, whereas in refractive, it is sort of rings around the point of focus. So it is a concentric rings around the point of focus, the defocus. So thus the problem of glare halos get more here, but there is no loss of light in refractive, whereas in diffractive, there is loss of light energy. As we still know that we are nowhere near God's natural multifocality that we get in young age, what our patient expects. As science is continuously evolving, we currently need to offer the best suited multifocal, trifocal, or EDOF lens with minimal side effects. Coming to history of mix and match, the concept of pseudophakic monovision was first put forth by Borner CF et al. In their study of 100 patients in 1984. The attempt of combining different models of multifocal IOLs asymmetrically, the so-called mix and match method, was first introduced by Jacobi F.K. et al. In 1990s. So what are the available IOL options today for us for mix and match? We have the gold standard monofocal IOLs and the monofocal extended monofocal IOLs. Accommodative IOLs no longer widely used. Extended depth of focus EDOF IOLs. Multifocal IOLs, diffractive and refractive. Trifocal IOLs, CRV IOLs like Technis Synergy, Technis Odyssey. Technis Odyssey presently is not available in India, but shortly Johnson & Johnson will be introducing it here. Coming to Technis Synergy, a word about Technis Synergy IOL combines diffractive technology from Technis Multifocal and Technis Symphony IOLs to deliver continuous high contrast vision across the range. Technis Multifocal IOL technology delivers good distance and near visual acuity. pupil independent design. Technis Symphony IOL technology delivers continuous vision across entire range that has chrome aligned technology that corrects chromatic aberrations to optimize contrast vision, thus making it a good lens for low light conditions. Again, it has a pupil independent design. So now we will be coming to what are the options of combinations we have. Talking about combination number one, that is monovision. This is to combine two monofocal IOLs with different focal points to achieve monovision. Targeting myopia of myopia -1 to -1.75 diopter in one eye allows for functional intermediate vision, whereas a target of -2 to -2.5 in one eye provides true near vision. But this we need to avoid because it is very difficult to neuro adapt. Only in patients who have used contact lens or who have been having asymmetrical vision right from the beginning, who have anisometropia, can probably neuro adapt to this type of monovision. So the monovision approach requires neuroadaptation, as I said, with suppression of the near eye when the subject gazes at distance objects and suppression of the distance eye when he focuses up close. Coming to pros and cons of monovision, the benefit of maintaining a high quality of vision with monofocal optics. Cons is the greater the disparity is between the eyes, as I already said, the more difficult is for the patient to neuroadapt. Now, who are the suitable candidates for monovision? Patients who cannot afford the premium multifocal or CRV lenses or EDOF lenses. Second is patients who have worn such correction in contact lenses, as I have already said. Patients who are at risk of developing eye diseases that will impact their contrast sensitivity later on, like glaucoma, macular degeneration, diabetic retinopathy, or patients who have undergone keratorefractive surgery, like excimer laser ablation, incisional keratotomy, because of corneal irregularities may already impact their contrast activity, acuity, and visual acuity. So such patients, as the example nowadays is going on in WhatsApp, now it has cooled down, Shah Rukh Khan. Combination 2 is combining a monofocal with a multifocal IOL, like extended monofocal like Technis iHense or Hoya Impress, in one eye, preferably dominant, and high-end multifocal or synergy in other eye. Coming to pros and cons of this combination 2. It allows both the patient's eyes to achieve excellent distance vision with the added benefit of some pseudo-accommodation in his multifocal eye. With any multifocal IOL, patient may experience positive dysphotopsias like glare halos and reduced contrast acuity. Most find that these symptoms diminish with time very fast when it is in non-dominant eye. When unwanted visual phenomena do occur, their presence in only one eye usually has a mitigating effect. Long-time near vision needing patients, especially those working on office files or those fond of reading, may not be satisfied and complain of overstrained eyes. Now I come to combination 3, that is to implant a EDOF IOL in both eyes. Here, the combination is of different powers, not of different type of lenses. So we target some myopia, that is minus 0.75 in the non-dominant eye. IOL can achieve a stronger near point, albeit with some sacrifice of distance equity in that eye. Combination 4, mixing an EDOF with a multifocal IOL. Pros and suitable candidates here are: this combination produces a quality of vision similar to mixing a monofocal and a multifocal lens, but patient's intermediate vision becomes superior. An EDOF IOL can be an appropriate choice for the second eye of patients who achieved good unaided near visual acuity with a multifocal lens in their first eye, but are struggling with glare and halos. But the patient says he or she needs good intermediate vision. So here a detailed counseling is must before we implant the EDOF in the other eye. And doing a dry eye workup is also must. Coming to combination 5, that is mixing two multifocal IOLs of different types. Who are the suitable candidates? When a patient seems to be comfortable with and adaptable to multifocal optics, but has strong desire to improve both his uncorrected intermediate and near vision. So mixing a low ad IOL like ZKB00 of plus 2.75 ad and a high ad IOL like ZLB00 plus 3.25 ad can achieve this result. Combining two trifocals, this gives excellent distance and near vision. The cons are the intermediate point of focus, as companies say, is not achieved. So higher incidence of PCO is also there in these type of lenses after 1 year, up to 35% in one study in Atlisa plate haptic hydrophilic with hydrophobic surface. This is the article in the Journal of Refractive Surgery, November 2016. This is the lens I'm talking about, which has a higher incidence of PCO. Combination 7 is we combine a EDOF like Alcon Vivity or a Lux Smart, which is a refractive EDOF in dominant eye and Technis Synergy CRV IOL in non-dominant eye. Combination 9 is just Technis Synergy CRV in both eyes. Here it is not mix and match. We are just using the same lens in both the eyes, targeting ametropia. Now the caution here is whatever I have talked is that we need to use toric models in case of astigmatism above 0.75 diopters. Coming to patient selection, which patient's eyes to be chosen? The choice of which IOLs to be implanted depends upon the patient's lifestyle, preference, and personality, angle kappa, angle alpha, and repeatability of biometric values. This is very important. Repeatability of biometric values. Several important objective variables to be considered are when selecting the appropriate lenses for a mix and match combination. We need to see patient's preferred reading distance, which can be used to adjust the IOL's near focal point, and we need to also do a corneal topography and pupil size. It is imperative to treat pre-existing conditions that may impair the patient's vision. For example, ophthalmologists should treat or manage malpositioned eyelids, blepharitis, especially the dry eye. Dry eye is very important here because if the patient has persistent dry eye which is not responding, and if we implant a multifocal IOL or a premium IOL here, the patient will have a lot of problems. And patient will always be unhappy and will never get a good vision. Now coming to, we just talked about choosing the right eye. Now we are coming to choosing the right patient. Can we implant multifocal in all patients who demand it? No. Most important points to be considered are personality, occupation, angle kappa, angle alpha, I've already said. Repeatability of AL and K values, I've already talked about. Neuroadaptation, which is something very difficult beforehand, before the surgery, to see which patient will neuroadapt and which will not. Personality, more suited are already heavily dependent on glasses, especially multifocal glasses, and very keen on spectacle independence for most tasks. Easygoing personality, positive outlook, would accept a small compromise in distance clarity, willing to understand that it is not a procedure with a granted outcome, and hypermetropic patients. Less suited are doesn't mind wearing glasses, hypercritical or hypersensitive, may have unrealistic expectations. Main concern is sharpest, clearest possible vision. Mild to moderately short-sighted tend to have excellent uncorrected near vision that is difficult to match or surpass. Personality. Now, at our center, the approach that we have is we have a set of questions at our counseling cell to recognize type A fussy and demanding personalities. First is how you feel when you are stuck up in traffic. What do you feel like if food in restaurant is not up to your taste or the waiter is late in serving you the food? How nicely kept room and your study you expect? And depending on the answers, we exclude some of the type A personalities for multifocal implantation, doing a detailed counseling to the patient and making him understand why we are not offering a multifocal implantation. And also those patients who have a lot of queries, especially written down and simply not will leave your chair. Occupation, avoid patients with excessive night driving or patients who need very fine vision like goldsmiths, etc. Coming to angle kappa and angle alpha, angle kappa is the angle between the visual axis and the pupillary axis at the cornea. Angle alpha is the difference angle between the center of the limbus and the visual axis. So that is the difference between where the visual axis passes and the center of limbus. Each eye has different angle kappa. They are usually less than 5 degree. Angle kappa and more specifically angle alpha is clinically significant because it can lead to multifocal decentration in perfectly centered IOL. If angle kappa is more than 6 millimeter, that is the total of x and y axis distance or more than 5 degree horizontally, avoid multifocal implantation in this condition. That IOL center will not be the center or will be far away from the visual axis. This is what I am talking about. You can see that the visual axis here is away from the center of the central ring of the IOL. So potentially unpleasant surprise will take place. So if a diffractive multifocal IOL is decentered relative to the visual axis, the patient may look through the diffractive rings rather than through the central optical zone, which can induce higher order aberrations. In the presence of high angle alpha, it is often recommended to deliberately decenter or nudge the IOL nasally in order to keep it on the visual axis. It may not be always possible, and however, to keep an IOL centered on the visual axis if the axis is not closely in line with the anatomical center of the capsule. With current haptic technology, the lens has a tendency to center in the middle of the capsular bag, which is most closely related with the center of the limbus. So measuring angle alpha, subjective method using sharp focusing light and observing first Purkinje image on cornea and its distance from pupillary center. Angle between pupillary axis and incident ray at pupillary center is angle lambda, which is nearly the same as angle kappa. Objective methods are synaptophore, OBSCAN, OPD scan, UBM, and corneal topography. Eye trace analyzes the central location of capsular bag, center of the limbus, where the IOL will center. Compare it with the center of the visual axis, and you will know if the IOL optics will be aligned properly. The eye trace gives you this angle alpha, and if the angle alpha is significant, multifocal will be misaligned and cause higher order aberrations, producing poor results. The ray tracing device color codes the amount of angle alpha, and angle less than or equal to 0.3 is green, 0.3 to 0.5 millimeter is yellow, and greater than 0.5 millimeter is red. Other important factors, I've already talked about dry eyes. I'll just talk about it again here. Healthy tear film, because this is a very important point. Doing a dry eye workup before implanting a patient with a premium IOL is must. Avoid bad ocular surfaces as light distribution and glare and halos are more annoying. Accepted RMS, high order aberration less than 1 micron. Happy patients less than 0.56 and unhappy more than 1.31. Avoiding macular pathologies as otherwise multifocal effect is lost and patient will have poorer vision than monofocal IOL. And repeatability of AL and K values, availability of optical biometers, preferably IOL mask 700 or Argos, or at least immersion biometer. Do not attempt these if you have only contact biometry. Intraoperative surgeons must pay special attention to the centration and positioning of the IOL, particularly with toric, accommodating, and multifocal designs. Improper positioning may not reduce these lenses' effectiveness, but it may also impair the patient's visual outcome. reducing the incidence of PCO and capsular phimosis through adequate size capsular access, symmetrical capsular shape, meticulous cortical cleanup, and proper capsule optic overlap. NSAID drops for several weeks post-operatively prevent CME, which even in subtle forms can impair contrast sensitivity. A plan to treat corneal astigmatism of 0.75 diopter or greater. If a toric IOL is not used, then the surgeon should consider incisional keratotomies or laser excimer ablation at a later date. And this is the correct sizing and overlap that I just talked about. And you can see the Purkinje images in the central ring and perfect capsular overlap 360 degrees. So tips to avoid side effects are patients with large pupils in mesopic conditions may experience worse dysphotopsias, especially at night and while driving. The low-ad multifocal or EDOF IOL in such eyes may reduce the chance of dissatisfaction. The answer here is putting the milder lens in dominant eye. The surgeon must remain aware of eye dominance when selecting eyes. By milder lens, I mean the lens, either a monofocal lens or extended monofocal or a multifocal lens with less ad, or a EDOF lens here if you are combining with a multifocal of high ad. Photic phenomena may exacerbate if the high ad lenses is put in the dominant eye. Typically, it is advisable to place the lens with less ad power in the dominant eye, since most uncomfortable photic phenomena happen for distance vision, and these lenses are better tolerated. Though this is not always possible due to advanced cataracts, asymmetrical cataracts, patient not willing to get the second eye operated soon, and so on. So we may have to place, under circumstances, milder lens in the non-dominant eye or a high ad lens or a multifocal lens in the dominant eye initially, if the patient is adamant of multifocal or a premium IOL like CRV lenses. Here we should prefer a CRV lens or a EDOF lens. Role of counseling and understanding patients' need is very important. The key to success with premium lenses is the surgeon's ability to clearly explain to the patients what they should expect from their vision after surgery. It is important to learn about patients' lifestyles, occupation, pastimes. Patient must be explained there is no guarantee that they will have no photic phenomena, but they are likely to be tolerable. Always be positive, don't be negative. Otherwise, your patient will go away to the other doctor. Additionally, they may need spectacles for activities with near vision, such as reading for long periods. Try to underpromise and overdeliver. When to avoid patients not suitable for mix and match approach include those who can't spend the extra money for multifocals, those who like wearing their glasses or aren't interested in spectacle freedom, those who say they won't tolerate any degree of halo or gear for multifocal lens. In my practice, the number of multifocal and mix and match is approx less than 10%. What is the approach at our center? We do dominant eye testing by optometrist, by finger pointing test or triangle test in patients having near symmetrical IMSC opting for spectacle independence. Otherwise, as per hand dominance, but this may not be always true. In one study, it said that 35% hand dominance may not give you the eye dominance. So we need to preferably do a triangle test here. In case we need to operate non-dominant eye first, detailed counseling must. But if patient meets the criteria, we do implant multifocals. Scenario 1, patient not interested in spectacle independence and willing to wear near aid. Now I'll be just talking about few scenarios that we face daily in our outdoor. Patients not interested in spectacle independence and willing to wear near aid glasses. This is near aid glasses, not near aid glasses, near aid glasses in both eyes. Choice of IOL, monofocal IOL for distance correction in both eyes is still the golden choice. Scenario 2, patient interested in spectacle independence but non-affording for premium IOLs or with comorbid eye conditions that we talked about, glaucoma, macular degeneration, or diabetic retinopathy, or dry eyes, severe dry eyes. Choice of IOL here is monofocal IOL with emmetropia in the dominant eye and monofocal IOL, extended monofocal IOL with minus 0.75 or minus 1 myopic correction in non-dominant eye. Monovision approach. Scenario 3 is affording patient desiring a good distance vision and near vision with compromise of intermediate vision, like housewives using mobile phones, retired professionals for reading newspaper. The choice of IOL is multifocal IOL with 3.25 ad in both eyes. Scenario 4, affording patients desiring a good distance vision and intermediate vision with minimal compromise of near vision. That is, office professionals with desktop use, drivers with night driving requirements. Here, the choice of IOL is EDOF IOL like concavity. Again, I will say it is not free of glare and halos. Lux Smart in both eyes. I have used very few Lux Smart, but it has given me good results. In the non-dominant eye with minus 0.75 myopic, that is a micro monovision. Hoya Impress, which is again a extended monofocal lens only, but this also gives a good intermediate vision. So we can have one eye myopic by -1 diopter implant, Hoya Impress, and CRV lens like Technis Synergy, or we can implant both Technis Synergy in both the eyes. Now coming to scenario 5. This is a housewife patient who needs to do kitchen work as well as use mobile phone for social media in our part-time. What is the best IOL combination approach in our case? Multifocal IOL with 2.75 add in the dominant eye and multifocal IOL with 3.25 add in the non-dominant eye. And presently, when 2.75 add lenses are not freely available, we can use Synergy or Alcon VVT in the first eye. Coming to scenario 6, affording professional patient who needs to do his office desktop work, wants to drive at night and uses mobile phone too often in his part-time. What is the best IOL combination approach in his case, his or her case? Choice of IOL, Technis Synergy, CRV IOL in first eye, and in case halos or glare while driving at night, either EDOF Alcon VVT or Hoya Impress in other eye, depending on the amount of glare and halos he has. If it is more, going for Hoya Impress in the other eye. And in case no glare or halos, we can implant Technis Synergy in both the eyes. Scenario 7, patient who can afford, who wants spectacle freedom as much as possible, but has dry eyes with a low tear breakup time. We have done the treatment for dry eyes, but still the patient has mild dry eyes and patient wants spectacle freedom as far as possible. So what is the best IOL combination approach in this case? The most forgiving lens in this type of conditions is a EDOF lens with emmetropia in the dominant eye and EDOF lens with minus 0.75 or -1 myopic correction in the non-dominant eye. Monovision or micro monovision approach with EDOF lenses. Thank you. I have tried to cover all the scenarios.
Dr. Neeraj, covered almost very comprehensive presentation. You've covered all the possible combinations and scenarios. I don't think there is anything left out. I am personally not a very big fan of EDOF lenses somehow, but like you said, for refractive IOLs, what students and younger surgeons need to remember is it is customization at every point, counseling and customization. Each solution, like you gave the various scenarios, it is customization to suit the patient. And a very important point that you brought out in the beginning, be very careful of finicky patients. They end up troubling you for a very long time. Identify these finicky and type A personalities and just avoid it in these patients. Personally, I've been using trifocals as a combination in both eyes, and I've had very good results in some of that study with a PCO rate of 35%. Somehow I don't agree with that, maybe some reason, but I've had excellent results with trifocals, and probably that is one of the best approaches in the suitable patient. Any experience with, say, you have a yellow chromophore lens and a plain lens in the other eye? Any problems that the patients have?
Usually, actually, I was a fan of Alcon because I was having an Alcon machine
Yeah.
initially. And then I got the laser of AMO. So I had to mix in many patients that Alcon in one eye and Technis one in the second eye.
Yeah,
And
yeah.
I didn't find much of a difference. Like no patient complained to me of any problem.
Any problem with blue light? So some of these patients tend to have some
Patients,
issues with the blue color.
they do say that once they are operated with the Technis one type of lens, they say that they usually see everything like नील से धुला हुआ जैसे दिखाई देता है, but not blue. They say it looks very white or bluish white basically.
Bluish white.
But that is for few days only basically.
Yeah,
Not
its neuroadaptation takes place and it tends to
usually
improve with time.
they adapt. Yeah.
Because I've also had this experience where you have a mix and match for whatever situation patients do. Some patients do complain of this bluish tinge in the vision. It tends to vanish with time. Over, I think, 2 to 3 weeks, it tends to go away when the neuroadaptation takes place. Dr. Praful, any comments? Just keep.
Dr. Praful, are you there?
Sir, I think sir is not online. Some connection could be.
Do we have any questions from the audience? Online, YouTube?
No, sir, there are no questions on YouTube and there are no questions on this website as well, sir. Sir has covered about IOLs very comprehensively, sir. Thank you for the wonderful presentation, sir.
Thank you.
Thank you.
I think I'll thank Dr. Kapoor and team iFocus for giving me this opportunity.
Sir, there are two questions.
Yeah.
Dr. Ishita has asked one question. There's only one question. Is there any change in contrast sensitivity due to mix and match of IOLs?
It actually depends that which lens you are using. Whether you are mixing, matching a diffractive, refractive, definitely diffractive will affect the contrast sensitivity, refractive will not. Second is that if you are using EDOF like Technis Symphony was there, which now they have converted to Technis Synergy, which is a combination of both. Again, they have got that technology in which there is a good contrast sensitivity here because of the technology in that. So usually in these lenses, but otherwise, when you use a diffractive lens, definitely yes, because of the light distribution, there is a decrease in contrast sensitivity. But again, as I said, if it is only in one eye, it has a mitigating effect. So patient will not complain that much as he will complain if the similar lens is there in both the eyes. So after implanting first eye, we need to question, we have to sit down with the patient, listen to his concerns, and then go in for the second eye.
Yeah, that is very important. Re-evaluation after the first eye, taking his concerns and then take time to re-evaluate and then decide on the best lens for the other eye to actually mitigate any problem that crop up when you have addressed the or implanted a particular IOL in the first eye, either in the dominant or non-dominant.
Okay, sir. So the contrast sensitivity is better in monofocal IOLs or with the EDOF lenses, sir. Like especially if we are having a patient as in a profession requiring very clear vision, like in a photographer. So what would be the preferred option? Monofocal IOL or an EDOF IOL, sir?
Monofocal is the best.
Best.
Monofocal, there is question about it. But then if the photographer says, no, I don't want to use glasses because I have to edit on the computer, I have to do so many things. Then we have to see that which is the best suited for him, because definitely all the lenses will have some amount of loss in contrast sensitivity, but which one has the least loss, we have to take that. And I think Technics Synergy in that case works well. But yes, monofocal is gold standard, no question about that.
Probably for such an individual, EDOF would be the best option.
EDOF Technics Symphony nowadays we are not getting actually.
Yeah,
That is
I know.
So that's why I said Synergy, which is a combination.
Synergy is it's a good option. Because a photographer for PC-based work would basically require intermediate vision. You wouldn't be too finicky about near vision. It's basically distance and intermediate which he's concerned about, and good contrast.
Okay, sir.
Technics Odyssey, which is shortly will be arriving in India, that the glare halos and the contrast sensitivity loss is again much lesser than Technics this thing Synergy, because they have sloped the step and made it more rounded in that. There is a technology they have adapted. So let's see what are the results before it enters our Indian market.
Are there any more queries?
Sir, I cannot see any more queries in YouTube or this platform, sir.
I think then we can conclude this session.
Yes, sir. Thank you so much, sir. Thank you, Dr. Prafula, sir, Dr. Brikapur, sir, and Dr. Neeraj, sir. It was a wonderful class, sir.
Thank
Thank
you.
you.